While the managing of opioid use disorder can be challenging enough, presence of co-occurring stimulant use disorder definitely adds a whole nother layer of complexity. In this mini video, we will review some key principles that you should consider when treating your patients with co-occurring opioid and stimulant use disorders. Let's use a case to illustrate. Allan is a 34-year-old HVAC worker who presents to your addiction program asking for help with his drug use. While he enjoyed a 12-month period of sobriety, he returned to use of illicit drugs about 8 weeks ago in the setting of his brother's recent unexpected death. Most recently, he states he's been insufflating 5 to 10 bags of fentanyl and about $50 worth of cocaine nearly daily, along with 2 to 4 milligrams of illicitly manufactured alprazolam. His escalating use is jeopardizing his job as well as his relationship with his girlfriend. Okay, that's a lot going on. Where do we even begin? Generally speaking, the current treatment options for stimulant use disorder, however limited they may be, can generally be used for patients with or without opioid use disorder. But there are some very important caveats, as we'll discuss. Let's review 3 key principles you should consider when managing co-occurring stimulant use and opioid use disorders. These include managing OUD first, the importance of defining patient goals, and the impact of additional co-occurring conditions. In general, we'll be grouping all stimulants together for the purposes of this discussion, whether your patient's using cocaine or methamphetamine, prescription stimulants, or some combination therein. So, our first principle is the prioritization of OUD. Now, we know that Allan's risk of overdose and death from opioids is dramatically higher than the daily risks associated with isolated stimulant use. Indeed, the leading cause of death among patients who use stimulants is cross-contamination with opioids and resultant unintentional overdose. It's estimated that 10 to 15% of cocaine is contaminated with fentanyl and its analogs, which are particularly dangerous for opioid-naive patients. So while getting stimulant use under control is certainly an important goal, the priority is to get Allan on a stable dose of MOUD, ideally with either buprenorphine or methadone. This can be achieved with sublingual buprenorphine or extended-release buprenorphine through a menu of different buprenorphine induction approaches as described elsewhere. It's worth mentioning here that patients with OUD who also have stimulant use disorder, like Allan, are significantly less likely to be initiated on MOUD. In a large retrospective cohort study involving over 200,000 treatment-seeking individuals with OUD, researchers found that while 46% of individuals with OUD alone were offered MOUD, less than 30% of individuals with a co-occurring substance use disorder, whether stimulants or alcohol, were offered MOUD. It's believed that this is largely due to an unwillingness on the part of MOUD programs and prescribers to permit ongoing stimulant use when MOUD is being prescribed. This reticence on the part of prescribers and programs is completely unfounded and ultimately endangers the lives of countless patients. We ultimately all need to embrace a harm reduction approach and accept that we'll never get a handle on our patient's stimulant use if our patient dies of an opioid overdose. Okay, using a low-dose induction, you first transition Allan to a sublingual buprenorphine regimen, and a week later, administer his first dose of extended-release buprenorphine. Not only is he now safe from unintentional opioid overdose, but he also reports his cravings from opioids are completely gone. Great! You've taken away a significant source of chaos, and you can now get to work addressing Allan's ongoing stimulant and benzo use. The next related factor to consider is the principle of patient-defined goals. Consider this. It's quite possible that the use of methadone or buprenorphine will rapidly stabilize your patient's opioid use, eliminating withdrawal symptoms and abolishing cravings. I mean, after all, from a morbidity and mortality perspective, we know that MOUD is one of the most effective interventions in all of medicine. So it should be no surprise that your initial efforts at addressing opioid use might be effective. With sustained abstinence from opioids, You might even be inclined to eventually space out patient appointments to monthly visits, particularly if your patient, like Allan, is stably on a monthly injectable form of buprenorphine. But what if he continues to regularly use cocaine? Is it okay to still consider him stable? To answer this question, you first need to identify what your patient's goals are. Perhaps Allan has no desire to cut out the cocaine at this time. Remember, the harm reduction approach: don't let perfection be the enemy of good enough. Perhaps Allan will eventually come around to the idea that cutting cocaine out of the picture would be in his best interest. For now, though, he just needs to know that you will support him either way, and that you will continue treatment of opioid use disorder regardless of his cocaine use. If, on the other hand, he professes a desire to cut out the cocaine as well, you may want to move away from monthly extended release buprenorphine in favor of either weekly extended release bub or a return to sublingual bub options. This will ensure that Allan feels compelled to come to your program on at least a weekly basis, helping to engage with you and your team, and ultimately helping him to achieve his treatment goals. Whether his goal is to abstain from cocaine or not, monthly visits are unlikely to promote the kind of patient engagement required to tackle the much more challenging issue of persistent stimulant use. Some clinicians might even mandate weekly appointments or even an IOP, even though they have achieved abstinence from opioids. Regardless of your approach, it's imperative that you continue opioid agonist treatment at all costs. Okay, Allan states that his goal is to abstain from cocaine as well, and he's willing to come in weekly while working on this goal. He reports that cocaine is helping him to focus when he's at work, and that without it, he gets easily distracted. So we now need to consider how the presence of opioid use disorder and other comorbid conditions might influence medication choice for treating stimulant use disorder. There are quite a host of medications that have been used with some success in treating stimulant use disorder. None of them are home runs, and none have been FDA approved for treating stimulant use disorder. The medications with the most robust evidence include topiramate, bupropion, disulfiram, mirtazapine, naltrexone, mixed amphetamine salts, methylphenidate, modafinil, and combinations therein. The combination of extended release naltrexone every 3 weeks and bupropion, 450 milligrams daily, in particular, has perhaps the strongest evidence among these options, based on a double-blind, placebo-controlled trial published back in 2021 in the New England Journal of Medicine. Most experts agree that it's reasonable to try each of these options in turn, insofar as they are relatively low risk, and they do seem to work for at least some subpopulations of patients with stimulant use disorder, even if somewhat unpredictably. In general, each of these options are safe to use for patients with concomitant opioid use disorder. The exception, of course, is the opioid antagonist naltrexone. While the naltrexone part of the aforementioned naltrexone and bupropion combination could certainly protect your patient from unintentional overdose, and it's a viable FDA-approved treatment for OUD, it's notoriously difficult to transition opioid-dependent patients onto naltrexone, particularly in the fentanyl era. As such, naltrexone is typically an unrealistic option when treating most patients with co-occurring stimulant use disorder. You'll also want to identify and address any comorbid conditions that may be contributing to stimulant use, including untreated ADHD, depression, chronic pain, alcohol use disorder, among others. Seeking out this information may lead to other treatable conditions that are exacerbating stimulant use, while also providing some clues that might influence the treatment of stimulant use disorder itself. So for Allan, for example, it's sounding like he may have some underlying untreated subclinical ADHD symptoms. As such, it would be reasonable from a harm reduction perspective to trial Allan on a prescription stimulant, such as mixed amphetamine salts or methylphenidate. Relatedly, what are the particular environmental triggers contributing to our patient's ongoing stimulant use? Perhaps it's the neighborhood in which he lives, a person your patient lives with who's also using, or perhaps your patient is subsidizing their habit by selling drugs themselves, which even further, more deeply entrenches them in daily use of cocaine. Otherwise, the treatment of stimulant use disorder in the presence of opioid use disorder really mirrors that of treatment of stimulant use disorder without OUD. You'll want to incorporate evidence-based behavioral interventions, particularly contingency management and cognitive behavioral therapy, the community reinforcement approach, or the matrix model. So, in summary, for your patients with both OUD and stimulant use disorder, like Allan, start first by addressing the OUD, preferably with buprenorphine or methadone. Once stabilized, elicit your patient's goals regarding stimulant use and work with your patient to devise a reasonable treatment strategy. And lastly, identify other potential co-occurring contributors to ongoing stimulant use and be mindful of how the presence of OUD and other co-occurring conditions might influence your choice of stimulant use disorder pharmacotherapy.